The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, everyone. Hello. We are gathered here for the next episode of TMD Demystified, and I am Tony Urbanek. Today's episode is entitled, and I'll read it to you if you allow me. The solution for TMD has been present for more than 50 years, but nobody bothered to connect the dots. And that is fact. The actual information that solves the TMD conundrum has been present for anybody to look at and find if they were willing to look. That is a generic problem, I believe, in societies. And I say societies plural, not just in the American culture, but in many cultures. I think it's somewhat human nature. But the fact is that all of the information that was available for me to look at and to study, but the information was there. I didn't create anything out of whole cloth that actually solved the conundrum of this thing that everybody calls TMJ, which is the name of the joint, temporomandibular joint. Official name, TMD, temporomandibular joint disorder, has been in the literature and other places available to look at for more than 50 years. So actually, I didn't really do anything that special to come up with a real solution for TMD, a non-surgical solution for TMD, but I did have the interest and the broad spectrum of my background and training and the willingness to remove all of my bias regarding this problem, primarily bias as a trained oral and maxillofacial surgeon, to actually look for and look at the facts of the problem, and with the help of my patients actually directing me where to look, came up with a rather simple solution. Now, these remarks that I'm making today are made primarily to the public, specifically the millions of women who have temporomandibular joint disorder. I have found that it is 90% females, 10% males. And the reason it's 90% females is one fact that's been in the literature for more than 70 years that has been overlooked and or ignored by the scientific community. And the fact is estrogen, the female hormone, exacerbates inflammation. And that is a fact. That's not my fact. That is a fact in the literature. And today, 2026 now, everybody has to fact check. So if you'd like, go ahead and fact check that fact. Estrogen exacerbates inflammation, and that is why TMD is primarily 90% female, 10% male, just like fibromyalgia is primarily a female problem. Why? Because estrogen exacerbates inflammation, and fibromyalgia is nothing more, nothing less than inflammation of the fibrous tissues in and around the muscles, fibromyalgia. So again, the title of today's discussion presentation is "The Solution for TMD Has Been Present for More Than 50 Years, but Nobody Bothered to Connect the Dots." And I, having experience and degrees in both dentistry and medicine, degrees in anatomy and cell biology, and quite a bit of research experience with my own research fellowship project with the National Institute of Health, National Institute of Dental and Craniofacial Research, as I was a young doctor before I came into private practice. I was familiar with research. I was familiar with aspects of medicine and surgery as a oral and maxillofacial surgeon, having training in both surgery, and then degrees in medicine and dentistry. I was able, once I took my biases aside and ignored everyone else's biases, the biases coming out of medicine, the biases coming out of dentistry, and actually started by looking at the problem from the viewpoint of the patient. And this is important to understand just from a scientific point of view. If you have a problem that doesn't appear to be solvable, the issue is you are either asking the wrong question or looking at or asking the wrong source. That is also a truism. And think about that, because I personally believe that there are no problems that cannot be solved if you know how to ask the question. First of all, you have to know how to ask the question. You have to ask the right question, and then you question or look for the answer from the right people or the right source. And in my first 36 years of oral and maxillofacial surgery, and as an oral and maxillofacial surgeon doing multiple types of reconstructive procedures on the face, both upper and lower face, cleft palate reconstruction, orthognathic reconstruction, cancer reconstruction, microneural reconstruction, and then, of course, tremendous amount of experience, 2,000 surgical cases on the temporomandibular joint. As a surgeon, you have bias toward surgery, expected to have bias. Nothing wrong with having bias toward what you are trained to do, but if what you're doing isn't effective or isn't as effective as it should be, then you need to ask yourself, well, maybe I shouldn't be doing this. We need to find a better way. And that's what I did. Roughly 15 years ago, I decided surgery was not going to be the long-term answer for temporomandibular joint problems after 2,000 surgical cases. And the reason I did is because a third of those patients would be back within a year or two with the same symptoms. No matter what kind of surgery I did for them, they would be back within a year or two with the same symptoms. Now, 2/3 of the patients did well, and that was good. And I still see, to this very day, patients filter into my practice here in Nashville area, Brentwood, Tennessee, that I have did surgery for on temporomandibular joint surgery for on one side, and they come in, now they're having problems on the other side. But fortunately, we're able to treat them non-surgically versus surgically, like I did decades ago. But the point being, I decided because a third of the patients would be back, I couldn't be honest with the patient and say, I'm going to fix you by doing temporomandibular joint surgery, knowing a third of the patients would be back within a year or two with the same symptoms. So I decided I had other things to keep me busy, other types of surgery to keep me busy, but temporomandibular joint surgery was not going to be one of them. And with my broad background in research and other information and training, I decided I was going to see if I could figure it out. And where do you start looking when you do science from the basic starting point of view. You start with the patient. And so actually applying that euphemism I noted, you either ask the wrong people or source, or you ask the wrong question. Well, I think the question is a correct question, to learn more about it, but the source that the other investigators were really asking was filtered out by a lot of bias from both the medical and dental community, and the source was the patient. And the questions were, what do you think about it? What makes it better? What makes it worse? What does your husband think about it? What phase of the moon is it when you have the symptoms? What can you tell me about this problem that I don't know? Which is exactly what I did. I brought in, rather than tell patients what kind of surgery I was going to do, and I had a long line of patients who wanted my help doing surgery on the temporomandibular joint. But instead of telling them after a consultation and certifying that they did have TMD, instead of telling them I was going to do whatever kind of surgery I thought was appropriate, I sat them down and said, I just want to talk to you. I want you to tell me all about it. What makes it better? What makes it worse? What do you think? Is there anything you can tell me about this that I might not know? And after interviewing 24 patients, roughly 24 patients over a period of 6 months or so, I would sit with them and I would spend 15 to 45 minutes, depending on how much information they had to share, and encourage them to talk. And out of 24 patient cohorts, I heard roughly 12 times, if I take my finger, a pencil eraser, my tongue, one lady said a piece of cloth, and put it between my front teeth and gently bite down, it feels better. I had never heard that before. And it made no sense to me. I just was like, what does that mean? But because roughly half of the people I interviewed, mostly women, almost all exclusively women, they said if I put something between my front teeth and gently bite down, it feels better. I went into my little laboratory and I made a device that went between the front teeth that I thought that they could speak with, talk with, they could breathe with it in their mouth. It was comfortable. And I gave it to the first woman in line and told her, put this in your mouth and come back in 3 weeks. Very simple device. All it does is do what the ladies said that they did, which was put something between their front teeth. Now, of course, a pencil eraser, your tongue, a piece of cloth, you can't keep it there very long, and you can't talk with it in your mouth. You can't drink with it in your mouth. But I designed this little device that they could. You can talk with it nicely, easily. You can drink hot and cold fluids with it in your mouth. You can breathe without any trouble at all. It's comfortable. You can't chew with it in your mouth because it's set up that, like they suggested, put something that only the front teeth touch and separate the back teeth. And that device is called the Urbanic device now because I couldn't call it the Save My Life device or Miracle device like my patients wanted to when we surveyed them. And I gave it to the first woman in line. This was 15 years ago. And I said, please put this in your mouth, keep it in your mouth 24/7, except when you eat. You need to take it out of your mouth to eat. And after you eat, brush your teeth, brush your device, put it back in, and come back in 3 weeks. When she returned in 3 weeks, I walked in the room and she said, thanks, doc, my pain's gone. Now, this was a typical female who had typical symptoms of headache, earache, jaw pain, neck pain, and some of the others of tinnitus and subjective hearing loss, shoulder pain. I don't recall all of her symptoms, frankly, But I do remember this particular woman in particular, because when I walked in the room and she said, "Thanks, doc, my pain is gone," I literally took a step backward, and the surprise on my face must have been obvious. And she looked at me and she says, "Weren't you expecting that?" I didn't admit to it. I didn't admit that she was an experiment. I did take a step back. I think I gave her a no answer answer. And I said, "I'm really happy that you're doing so well." And that was the beginning. That was the beginning of my investigation and travels to figure out how putting a device between the front teeth and using it, as we now know, according to appropriate protocol, because it isn't the device itself that does all the work. It is a tool to use, and you have to know how to use the tool. And then we had to work out the proper protocol, how to use it, depending on the patient's presentation, circumstances, and symptoms. And that's all been worked out. So it's a device and protocol. It's not just a widget device. It is a device and protocol that needs to have some knowledge behind it from the doctor's point of view, the provider's point of view. It isn't something you buy in the drugstore, or you just get any old dental lab to make it and put it in the mouth and hope for the best. So the doctors who use it have to have some training as to exactly how it works and what you're doing with it, which I hope to explain here in just a minute, because that was where the research came in. It didn't take much research for me to have 12 females to say, if I take my finger, my tongue, a pencil eraser, and put it between my front teeth, it feels better. The research came from what's going on when you do that. So after another, dozen or 20 cases, I found that the results were all similar. Patients would come back within 3 weeks and say a significant portion, if not all, of their symptoms were diminished, decreased, or gone. Now, we now know what the averages are after the first 3 weeks of 24/7. You don't have to wear it 24/7 for the rest of your life, but it is very important that you start out strong. Again, with the understanding of what you're doing with this device. So, but all of the patients who came in said a significant portion of their symptoms were diminished or decreased within the first 3 weeks, and then we followed them along up to 2 months, then 4 months, and 6 months. By the time patients were into the 4th or 6th month, they were given numbers like 80, 90, 95, or 100% of their symptoms were diminished or gone, as long as they followed the protocol. So what's the protocol? The protocol is to wear it 24/7 for 2 months and nighttime only indefinitely the rest of your life. Unfortunately, not everyone follows the protocol. That is true. That's called patient compliance, and that is a problem with any kind of medical dental treatment, getting patients to comply with the proper use and protocol that's designed to use whatever you're doing. But that's more of the story and the training that doctors need to find out about when they want to be licensed to use this device and protocol. But for the patients who are listening, I just want to emphasize the protocol is very important. It is critical. But if you do the protocol and you use the tool correctly, you will get the response. And of course, I've said on many of these episodes, the symptoms themselves are very disparate. That was the problem, the conundrum, the confusion that the dentists were left with, trying to solve this problem that was called for 50 or 70 years TMJ, which is the name of the joint, rather than the name of the problem. It's like going to the orthopedic surgeon and announcing you have knees. I think you'll confuse the poor orthopedic surgeon when you walk in and say, "I have knees." So TMD, temporomandibular joint disorder, came through an understanding that the solution for TMD came through an understanding of the fact that inflammation within the temporomandibular joint creates all of the disparate symptoms. And to this very day, January of 2026, those treating TMD inappropriately don't address the cause, which is inflammation. They just, at very best, try to address the symptoms and use stuff that is inappropriate, like botulinum toxin A, better known as Botox, or dry needling, or drugs of multiple types, throwing drugs at the wall to see if they'll stick, steroids, muscle relaxants, narcotics, opioids of many kinds, pain medicine. The thing that really surprised me was that the direction to look at could have been easily developed by looking at what we know works for a short period of time, which are nonsteroidal anti-inflammatories. We know that nonsteroidal anti-inflammatories, just Motrin, ibuprofen, work really well, but only for a short period of time. And they're really damaging. If you use them too long or too much, they can damage your liver. Don't want to do that. Can't do that. But they are effective for a few weeks. You get maybe 2 weeks out of using them, and then they run out of steam. They just aren't effective anymore. But what do they do? Why are they effective? They decrease inflammation generally throughout the body. I mean, they work not just on the temporomandibular joint. If you're taking a drug, that's the problem with drugs. You got to take all their side effects with them. And drugs have many side effects. And the physicians tell a patient, we're giving you this drug for this reason, but they don't emphasize that you got to take all the side effects that come along with the drug. Well, ibuprofen has side effects too, and we know that they are very effective on inflammation throughout the body, including if you have inflammation in the joint. But if the scientists, the doctors who investigate temporomandibular joint would have just focused on trying to figure out the easiest and best way to treat inflammation within the temporomandibular joint, they would have, hopefully someone long before me would have understood that if you unload a joint adequately over a period of time with the understanding of what you are doing is the easiest way to treat TMD because it allows the inflammation to decrease. That's all you're doing. Just like a set of crutches allows inflammation on the knee to decrease, that is why it stops hurting if you are on crutches. If you have a bad knee and go to the orthopedic surgeon and he does his very extensive workup and he says, we think we need to do surgery on this joint. And if you say, I don't want to do any surgery on my knee, what else can I do? Well, nowadays he'd say, well, we'll do injections in the knee for a couple of years and then we'll do the surgery. And you say, no, I don't want the injections and or the surgery. What can I do? He would hand you a set of crutches and say, if you stay on these crutches, I promise your knee pain is going to go away. And he would be correct 100% of the time, 100% of the time. This device does nothing more, nothing less than takes the load off the temporomandibular joint and allows the ball to fit well in its most comfortable position in the socket of the temporomandibular joint and allows inflammation to decrease to the point where all the symptoms go away. And my discovery, if there was any discovery, which was the point of this episode, was always in the literature. But the discovery was how inflammation within the temporomandibular joint creates all the symptoms. So there were 3 parts to that, quote, discovery that was already always present. The first part is that every dental school and every dentist knows that 90% of the loads on these joints come from the posterior teeth. 90% of the loads on these joints come from the function of the posterior teeth. You have to crack nuts with your back teeth, not your front teeth. It's set up, proprioceptors are set up on the teeth that they don't allow significant forces on the front teeth. The front teeth are not set up. They don't have the root structure to allow that kind of force. So you have to do the majority of forces on your back teeth. They have multi-rooted tooth teeth. Some of them have 3 roots, very, very substantial teeth that allow tremendous amount of force on them, which then transfers into the temporomandibular joint. So the first point that explains how inflammation within the temporomandibular joint creates all the disparate symptoms is you have to understand that 90% of the loads on these joints come from the posterior teeth. The second point is demonstrated easily and known by just about every surgeon who treated the temporomandibular joint, and that is 100% of the time the pathology report on a temporomandibular joint comes back as, no matter what else it says, chronic inflammation. Chronic inflammation is involved with every type and every single problem, whatever the symptoms were, whatever the patient's descriptions were, however long it's been there. If you do surgery on a temporomandibular joint, like I did 2,000 times, the pathology report returned 100% of the time chronic inflammation. It may have included some other information from the pathologist about that joint, but line 1 of the pathology report was always chronic inflammation. So you must assume that if you have TMD, you have chronic inflammation within the temporomandibular joint. That is point 2. And the point, and the third part of the tripartite description that explains how chronic inflammation create the disparate symptoms is the fact that the orthopedic surgeons know and have known for quite some time, going back to my early education, that if a joint is inflamed, it sends signals to the brain stating its condition, I'm inflamed. The brain then tries to help by sending signals through the nervous system for the information of the doctors through this autonomic nervous system. The sympathetic portion of the autonomic nervous system sends signals back to the muscles, instructing the muscles to tighten up and don't move the joint. Now, in the case of other joints in the body that the orthopedic surgeons know about and use, the best example of this is the elbow. And when the elbow gets inflamed, and that is called tennis elbow, too much repetition, not just of tennis, but any repetitive process of the forearm can create tennis elbow, which is inflammation of the lateral epicondyle right there. The lateral epicondyle becomes inflamed, and that lateral epicondyle sends an autonomic signal to the brain stem, and the brain stem gets that signal, modulates it, and sends a signal back down. Don't move that joint. We're going to try to help you out. Don't move it. Allow the joint to heal. And it sends signals to the distant muscles that move the joint. In this case, the muscles are in the forearm and extending all the way into the wrist, where the attachments are of the muscles throughout the forearm and into the wrist. And tennis elbow is, they don't complain of pain here, they complain of pain in the forearm. That's called tennis elbow. And that same phenomenon, which is well known to the orthopedic surgeons, operates this joint, applies to this joint. And every dental school in the country teaches to this very day, and I stand by it because I've done the investigation, every dental school in the country to this day tells young doctors, young dental students, that this joint is different, it is unique, it's not like any other joint in the body, and it doesn't operate like any other joint in the body, and that is not true. This joint operates just like your knee and your hip and your elbow as it applies to that phenomenon called joint splinting. That's what the orthopedic surgeons call it. They call it joint splinting. It splints the joint by the muscles that tighten up. It just so happens that the muscles that move the jaw are all over the face. They aren't just here. Actually, there are 5 major muscles, which I'm not going to define for you. I'll let the doctors look it up in their anatomy book. And nowadays, if you're interested, you can look it up on the internet or ask AI. Where are the muscles inserted? Where's the origin and insertion of the muscles that move the jawbone, the mandible? And you can look them up, and they're all over the place. They're up here, they're down here, they're up here. And then when the problem isn't solved, the brainstem says, I told you I'd hold the jaw still. Now I want you to hold the whole neck still. Hold it tight. Hold it tight. And signals come down to tighten up the muscles of the neck. And where they're inserted, both in the upper back and throughout the neck, then people complain of neck pain is the second most common symptom of TMD. Headache is number 1. Of course, my medical colleagues can't solve migraines. They have no idea what causes migraines. And we know that headaches, bad headaches, are confused with migraines all the time. And patients are placed on migraine medication when they really have TMD. And the ENT doctors place patients on various medications that don't work, and they have no idea what causes ringing, fullness, dizziness, which is the second non-symptom, non-painful set of symptoms associated with TMD, but caused by the same thing, inflammation in the joint that gets into the middle ear. So inflammation in the temporomandibular joint causes painful symptoms throughout the head, the neck, and the upper shoulders, including arm, hand, finger tingling and numbness. And the non-painful symptoms, inflammation in the joint that filters through a little hole or fissure into the middle ear. It's called a petrotympanic fissure, which allows inflammation to get in the middle ear, which causes ringing in the ears, feeling of fullness in the ears, which we call subjective hearing loss, and vertigo, dizziness. Those are well-known symptoms associated with TMD. No one argues with that, but no one ever stopped to figure out or look in an anatomy book and look up the petrotympanic fissure that allows inflammation to get into the middle ear. So it's all about inflammation. Inflammation creates all of the disparate symptoms of TMD. It's profound. But all of that information has been available for people, doctors, to look at if they had removed their bias and looked at a study that started by asking the right people or the right source. The right source in this case was women with the problem. 24 of them in particular, 12 of them exactly, who gave me the information or the place to look, put something between the front teeth, and then you had to work out with a little bit of investigation in the sciences, reading about joint splinting, having knowledge that chronic inflammation is involved in 100% of TMD patients, and knowing something that's commonly known in dental school, taught in dental schools, that 90% of the loads on the temporomandibular joint come from the posterior teeth. If you know those 3 facts, anybody could have figured this out. But there is a device, there is a protocol. It's very simple for the patients. You can look into this and find a doctor who is licensed to use this device in your neighborhood by looking at the available doctors who are licensed to do it and throughout the United States at www.urbanektmj.com. If you are a dentist who would like to do this for your patients successfully, with success rates literally 95% success rate, as long as patients follow the protocol and get trained to do this, it's very easy to train to do this. Again, you can get information to contact our company at www.urbanektmj.com. Those of you who'd like to contact me personally, I'm available at tony@tmjservices.net, Tony@tmjservicesplural.net. With that said, I just want to repeat, the solution for TMD has been present for more than 50 years, but nobody bothered to connect the dots. And fortunately or unfortunately, sometimes I wonder whether it was fortunate for me or unfortunate for me to have connected those dots and am now, because I know the facts, it is only ethical for me to allow as many people to know this information, to put this information as widely as I possibly can to the public, and especially to the doctors, and especially to the doctors who misdiagnose this problem as migraine headaches, ear infections, and Meniere's disease. And sooner or later, it will be accepted as standard operating procedure. With that said, I look forward to the next episode of TMD Demystified. I hope the information I shared with you today is meaningful. I hope it makes sense to you. I encourage you to fact check it. Please fact check it, because it is the fact. I'm Tony Urbanek, and this is TMD Demystified.